Welcome to Inside the OT. Today we're going to see how to perform a safe laparoscopic cholecystectomy from port placements to the specimen retrieval. As usual, any laparoscopic surgery, first we're going to do a diagnostic laparoscopy using a 10 mm primary camera port at the umbilicus region. So once you have done a diagnostic laparoscopy, then is your secondary port placements. So for first secondary port I'm going to put is the right lumbar port, which is basically the gallbladder retraction, where I'm going to assess the anatomy. Now once I've seen, then I'm going to shift on to put the epigastric 10 mm working port. So this will be the first secondary working port, and then you another 5 mm working port in the right midclavicular line, which will be a second working port. So these are the standard port placements, where one 10 mm in the epigastric and two 5 mm in the right lumbar in the anterior axillary and the right hypochondriac in the midclavicular line. So you see here there are a few omental adhesions to the gallbladder. I'm slowly dissecting those omental adhesions by not perforating the gallbladder. Look at the tip of my instrument. This is what is important here. The tip should be faced towards your specimen organ. So this video is running in 1.5 speed with minimal editing, where the fogging of the scope is just edited. So see, now those momental additions have been dissected. Now we can see there's the entire body and the hartments of the gallbladder is coming into the vision. And the ease of performing a lap cholecystectomy is to have a really good working left hand, where you'll be manipulating your hartments for the calyx dissection. You see, your left hand, you're trying to push the gallbladder infromedially and then try to dissect the posterior peritoneum. So, step number one, posterior peritoneal dissection, where you're gonna start your dissection well above the ruvius sulcus. And now I'm just dissecting some of those adhesions from stomach to the gallbladder. So you see, in this case, there's actually a fused dubious sulcus, where you can see just the lateral opening of the pedicle, and we are well above it. So the dissection always should start well above your rubius sulcus. And the R for you rule is there's a line joining the rubius sulcus segment for the liver under your umbilical fissure. Our dissection should always be cranial to the line joining these for a safe dissection. So now you have done your posterior dissection. Now we'll shift on to our anterior peritoneal dissection. So I'm just releasing the gallbladder from the gallbladder bed, from the liver basically. And you see, the principles of achieving critical view of safety is you have to dissect 1/3 of the gallbladder from the gallbladder bed, where you can see the liver underneath the gallbladder. Then you're gonna shift on to your calyx dissection. So over here you see I'm trying to dissect the gallbladder off the gallbladder bed. So in such cases where you can't retract the gallbladder, what you can do is you don't have to hold the gallbladder. Instead, you can see my instrument, the left hand instrument. I'm just opening the jaws and then trying to retract it infralaterally. You see, so this is how you do. This is not. I've learned it from one of my seniors. Uh, so yeah, we have slowly. I'm just trying to dissect the gallbladder from the gallbladder bed. And never jump into your calyx dissection before you do an adequate mobilization of the gallbladder from the gallbladder bed, because I mean it only the calyx actually opens up only if you actually um, dissect the gallbladder from the bed. You see, I'm doing some more of the posterior peritoneal dissection, which I've not completed initially because the gallbladder was snugly adherent to the liver. And you should do both simultaneously, anterior and posterior dissections, to achieve a good critical view of safety. And while doing your anterior and posterior dissections, the camera person plays a major role, where would like your assistant show you the proper angles. So you see, now I'm like trying to dissect the calyx triangle and I'm trying to sweep off the fat. You see, the tip of my instrument is never facing down, it should always face above. You should clear all the fat in the calyx triangle to visualize the cystic duct and cystic artery. So you see, I'm trying to dissect off all the fatty structures. So this is what I was talking about, the dissecting the one third of gallbladder from the gallbladder bed. You see, that's what I'm doing right now. I'm doing it both anteriorly and posteriorly. So you see, now one third of the gallbladder is mobilized, and you see, this is called the elephant trunk appearance. Now you have to dissect to see the cystic artery and the cystic duct. And so yeah, that is your cystic artery, where I can make a plane there. So always use a Maryland, and the plane should always be created craniocaudally rather than anteroposteriorly, where there is always the risk of snapping the cystic artery. So usually in my practice, I won't clip the cystic artery. I use a good vessel sealing device to seal it. So once the artery is burst, then it's time for us to clipping the duct. Always use a habit of using the Hemalock clips, which are secure. And on the specimen side, I generally prefer using a Liga clip. So yeah, now the duct is cut. And now is your gallbladder bed dissection. And this is the most important step where you can inadvertently enter the liver in case of intrahepatic gallbladders, and then you can injure the middle hepatic vein or a subvesical duct which you can't see, and then it lead to a torrential bleed in case of middle hepatic vein injury, and minor bile leak in case of subvesical duct. So just stick to the areola plane whenever you see when there's an overcharging of tissues. Then you have to make your dissection a little above because you're basically in the liver. So you see now that is in a clearly like areola tissue, and then I'm using a vessel sealing device. There's a really good bloodless field when you're in the right plane. You should always respect the cystic plate. So when you respect the cystic plate, it will make your life easier. And there are the final bit of cystic plate dissection. And it's done. So the next step is to put a endo bag for specimen retrieval. And at the end, make it a habit to have a look at the clips and secure hemostasis. Thanks a lot for watching this video. Please do like, share, and subscribe for more educational content.